association between acid reflux and Barrett's esophagus was first described by Norman Barrett in the early 1950s when he noted these pinkish orange, what we call salmon-colored tongues of mucosa lining the distal esophagus in many patients. Barrett was actually a surgeon, and he was actually mistaken in his assumption, because what Barrett thought was that patients with Barrett's esophagus had a congenitally shortened esophagus with an intrathoracic stomach. And the pinkish orange lining that was in the esophagus, he believed was actually stomach in these patients. And it wasn't until several years later when another surgeon, Philip Allison, actually looked at several patients with the disease and realized that the pinkish orangey tongues of mucosa were not in fact the stomach in the thorax, but in fact an alteration of the lining of the esophagus. The normal lining of the esophagus is typically what we call a squamous epithelium. In Barrett's esophagus, due to chronic acid-related injury, that epithelium changes. The lining starts to resemble other parts of the GI tract, specifically the intestines. And it's believed that this lining may be more resistant to the effects of acid-related injury, but in fact, this response is actually maladaptive because it's the predominant precursor to cancer. The initial pioneers in the field were thoracic surgeons, because they were the ones that were able to see Barrett's esophagus, because they were the ones that were removing and examining the esophagus. But today, Barrett's is predominantly managed by gastroenterologists because of modern endoscopy, and there are numerous innovations in this technology which have really arisen over the past 10 years. Today's endoscopes are all high definition for the most part, just like your high definition televisions, cable television today. We have the ability to magnify the lining of the GI tract up to about 1,100 times. And we have some really remarkable innovations, including confocal microendoscopy, which provide a microscopic view of the Barrett's esophagus and the lining of the GI tract. We can actually see cancer and what is known as dysplasia or precancer at a microscopic level, including the nuclei and the glandular lining of the esophagus. This really increases our ability to detect and treat cancer at a very, very early stage before it's breached the epithelial barrier and before it's infiltrated into any lymph nodes or vessels. And so endoscopy and advances in endoscopy have really dramatically improved our approach to these patients, because not only can we see cancer at an early stage, we can treat it in a minimally invasive fashion through our endoscopes, potentially sparing the patient major surgeries and removal of their esophagus.